first talk, which is the role of chemotherapy in driver-positive patients. Dr. Jared Weiss, an associate professor at University of North Carolina, vice president of GRACE, and a wonderful lung cancer doc, is going to be giving us his take on the role of chemotherapy for driver-positive patients. Dr. Weiss?
But I've been given the challenging talk of speaking about the role of chemotherapy in driver-positive patients. And this summarizes my feelings on the use of chemotherapy in driver-positive populations. I've, in roughly 20 years of having some involvement in the care of cancer patients, I have come to love targeted therapy for its human advantages. And I have spent a long time researching very hard to bury chemotherapy, not to justify its ongoing use. If that weren't strong enough feelings of my own, these represent my feelings on trying to justify the merits of chemotherapy to an audience composed of patients and those who love patients. You're looking here at a internet Dr. Google stolen picture of La Tomatina, which is a festival that happens in the summer every year in Spain, and is exactly what it looks like. A bunch of people throwing tomatoes at each other. Thankfully, we are in a completely virtual forum, so I suppose I found very few nice things to like about COVID-19, but it's protecting me against your tomatoes. As far as why I hate chemotherapy, and I suspect why you hate chemotherapy, this is probably very obvious to most, but chemo causes awful side effects like fatigue, nausea, risk of infection, risk of neuropathy. And since it's IV, in addition to the extent to which it medicalizes life by causing adverse events, I would add to it that it's insufficiently active, so that at least compared to targeted therapy, it's not relieving the suffering of cancer nearly enough. And to make matters worse, it's intravenous, which means that you need to spend hours in an infusion chair instead of being out enjoying life. There's really only one thing that, to my mind, can ever make chemotherapy look good, which is cancer. And as I said, after a long time of treating cancer patients, I have come to hate cancer even more than I hate chemotherapy, because I've seen a lot more total suffering from cancer than I have seen from chemo. Like chemo, cancer can cause fatigue. Its other humoral side effect is thrombosis, or blood clots. And whenever cancer presses on a nerve, it causes pain. When cancer presses on airways, it causes cough and shortness of breath. There's a nerve in the chest called the recurrent laryngeal nerve, and when cancer presses on it, it causes hoarse voice. Presses on the stomach, it causes nausea, like chemo. It can also cause anorexia. And like chemotherapy, it medicalizes life because it causes suffering directly and causes the need to spend time in the doctor's office. And of course, most obviously, but very importantly, cancer shortens life. And so in a world where the comparison is targeted therapy versus chemotherapy, it's very easy to reject chemotherapy because targeted therapy is great taste and less filling, right? It's more effective and less toxic, and it's a pill. So in every way it can be better, it's better. There's really no controversy. The human merits of targeted therapy kick the pants off of chemotherapy and the pants off of no treatment at all. When it comes to the question of chemotherapy, if we want to maximize global quality of life, then we really don't have the luxury of ignoring either the suffering induced by the treatment or the suffering induced by the cancer. They have to always be considered together. Where does that fall out for considering chemotherapy in a driver-positive population? The most common situation is after all available targeted therapy has been used up. Second point, if the chemo is more effective than the targeted therapy. So the last time that this was clear that this was true for me, and it was actually less toxic as well, was the case of RET prior to the approval of selpercatinib and pralsetinib. Before that, we had cabozantinib and vandetanib. Others may feel different. We'll have a panel shortly. But my opinion is that not only are cabo and vandetanib less effective than cytotoxic doublet therapy, for many patients, they're more toxic. And so in that situation, I favored chemo over the so-called targeted therapy. As we enter an era of efficacy of targeted therapy against KRAS G12C, I think there's room to argue which is more effective and in which patients toxicity is optimized. And as we get newer and newer targets, that's going to be an ongoing question, right? We love targeted therapy and hate chemotherapy because of the human reasons, not for an inherent abstract reason. We care about duration of life, we care about quality of life, and when in emerging situations, chemo is better on these dimensions, it needs to not be discarded. Next item on my bullet list are niche situations. So the longer patients live, the more complex their care becomes. It's a very high quality problem, but when you think about the targeted therapy patient who's been alive and thriving for years on targeted therapy, you get into more of these complex situations where you have clonal heterogeneity, cancer is well controlled in one place but not the other. You have to spend lots of time going through history and slides to say which drug is controlling it in which locations. You get into creative approaches that really require expert management and close partnership between patient and provider team. And there are situations where chemotherapy might be the better answer in some sequence or in combination with a targeted therapy. I'm about to discuss the data on when chemo is already started. The answer is actually a little bit surprising in favor of chemotherapy and maybe in combination with chemo. So the easy question, if it's phrased this way, is how bad is it to not give targeted therapy? You've seen these survival curves at least 3 times today, so I won't go over it yet again or explain it yet again. But the gist is it's really bad to never give targeted therapy, either because the doctor failed to do the testing or because the testing was done and then never actioned. But if you rephrase the question, what about using chemo first? The answer is actually a little bit surprising. So most of this data exists from the EGFR era, although I suspect the answer is really very much the same for most of our targetable mutations. We have a series of studies comparing chemo to targeted therapy in the frontline, and they always show a better response rate for targeted therapy. They always show longer disease control with targeted therapy. What they almost never show is a survival advantage for the use of targeted therapy first. So if we know a priori at the beginning of care that a patient has an actionable driver mutation, we would always treat to that driver mutation. It's practically religion amongst this crowd. And the reason that my colleagues and I feel that way is largely human, right? All the wonderful benefits of targeted therapy, at least compared to chemo, that we've talked about today. But I want to address a slightly different question, right? We talked in the first session about impatience with therapy, that sometimes for provider-driven, disease-driven, or patient-driven reasons, chemo starts and we get back the molecular result later. What we didn't talk about this morning was what to do with that. And so there are 3 answers. I think the most common answer from academic experts is to switch immediately to targeted therapy. And I think that's because we all worship, for a very good reason, at an altar of targeted therapy. But the truth is the data doesn't support that that's the only answer available. In an environment with aggressive and quality supportive care, as well as aggressive and frequent disease surveillance, which summarizes to say that once the chemo stops working, the patient is going to be brought quickly onto targeted therapy, or in doctor talk, guaranteed crossover. It actually looks like there probably is not a survival advantage to using that targeted therapy first. And so a second option is to do whatever you would have done in a driver negative patient. So for example, if they got PEM-carbo-bev, continue bev maintenance. If they got PEM-carbo, continue PEM maintenance, and switch to TKI at the first sign of progression. That's option 2. Third option is to finish those 4 cycles of chemotherapy and then switch to targeted therapy. And this is supported by an old study that I don't even teach my fellows about anymore called Saturn. Saturn took patients unselected by molecular status and randomized them after non-progression of 4 cycles of chemotherapy to either maintenance or erlotinib, which is an older first-generation EGFR TKI, or to placebo. And later subgroup analysis that you're looking at here shows that amongst those with EGFR mutation, there was a dramatic progression-free survival or disease control advantage in the use of erlotinib subsequently. And so I think there's nothing wrong with this third strategy in a patient who is tolerating chemotherapy well, and is deriving benefit in terms of disease control, I think there's nothing wrong to going to 4 cycles and then switching. I think it's more politically correct in my world to switch immediately to targeted therapy and in a nod to its general superiority. But putting on my white coat for a moment, I worry about using up the chemotherapy. I worry about giving some and not knowing if it's working for patients. So my preference is to go to, in a patient who is tolerating and who seems to be deriving benefit, to go to 2 cycles to scan. And then if the patient is still tolerating and if there is a response, to give cycle 3 and 4 and then switch to targeted therapy. But I think there's still nothing wrong with switching right away, or even pursuing your standard maintenance strategy in driver negative patients and giving TKI at first hint of progression. I suspect when we get to panel discussion, some of my colleagues feel otherwise. A critical question you may be asking at this point is, how well does the chemotherapy work, right? All of us keep saying no, no, no to chemotherapy, and I'm in that camp. And it might give the false impression that chemotherapy doesn't work in a driver positive population. That's actually not true at all. You're looking here at old data back from when it was still a question of second-line osimertinib versus chemotherapy. That's not a question that's really that active in our practice anymore, but I show you this to show you the PFS curve of the chemotherapy. It looks at least as good as what we see in driver-negative patients. Subsequently, multiple studies have come out looking at chemotherapeutic regimens in the driver-positive population. At left, you have data from Tom Stinchcombe's study of pemetrexed, carboplatin, and bevacizumab in never smokers, many of whom had EGFR mutation. And we see here is a PFS of over a year, response rate of nearly half, only 13% of patients having progressive disease as best response. What you see at right is retrospective data looking at patients who got carboplatin and paclitaxel, once a dominant chemo regimen, or carboplatin, paclitaxel, and bevacizumab, showing superior disease control and survival in those who got bevacizumab. And this is concordant with other data showing that suggests that Bev may be a particularly active agent in our never smoking or perhaps EGFR driven cancers. And so when I use chemo, Pem Carbo Bev is a regimen that I strongly consider. I caught the tail end of mention of this regimen, the Empower regimen of carboplatin, paclitaxel, bevacizumab, and atezolizumab. And when the data on this regimen first came out, I shrunk away in horror. I don't like paclitaxel compared to pemetrexed because it's more fatiguing and causes more neuropathy. But there are, and I didn't like the idea of a 4-drug regimen. I suspect I'm not alone in having these biases. But what you're looking at left is the initial data we saw in patients with EGFR or ALK. I'll note that mostly these were EGFR patients. I don't think we can say a whole lot about ALK. And in fact, when subsequent analysis was shown at right, it was restricted to EGFR. And not surprisingly, the curve looks nearly identical for PFS at top and survival at bottom. And so I think this is where patient preference really needs to come very strongly into play. When I started counseling patients about the option of this regimen, I thought no one would take it. Many of my patients, when they start targeted therapy, say something to the effect that they'll never consider chemo once targeted therapy is used up. Many people say they would most consider hospice at that point. But when faced with the decision, a surprising number of people change their mind. I think underscoring the importance of us continuing to talk to our patients and making sure we understand their values instead of assuming that they're still the same. You'll get a lot of opinions. This is extremely controversial, but I think it's an option that at least deserves discussion, at least with the EGFR mutated patient, because it may be that we can bring the benefits of immunotherapy to an EGFR patient. Multiple historic studies have looked at the addition of chemotherapy to TKI in the front line, at least with older TKIs. One such study added Gem-Cis to gefitinib and showed a PFS and OS advantage. Another did the same thing with pemetrexed and carboplatin. These are older TKIs. I have no temptation to go back to erlotinib or gefitinib, but I stand with the majority in favoring osimertinib. But there is study ongoing in the context of osimertinib to ask whether chemotherapy might add to osimertinib in the frontline. I must confess to having mixed feelings about what I hope to happen. On the one hand, any advantage to survival for our patients is of value. On the other hand, I think it creates an uncomfortable situation having to use a cytotoxic in frontline. There are obvious human benefits to non-cytotoxic frontline therapy, and if the benefit is marginal or non-large, maybe is a better way to say it, then I think it's going to have to be a careful conversation in the clinic where different patients may choose different things. I like to add, to end all of my Grace talks with a cute kids picture, or at least I think they're cute, but I'm genetically programmed to think that. These are the twins, Betty and Dina, and my youngest, Charlotte, at a recent trip to the beach. I thought that might be an up note to end on that will maybe stop the figurative tomatoes after talking about chemotherapy.